Hello, today we have lecture number 9, respiratory failure. Acute respiratory failure is a life-threatening impairment of oxygenation, carbon dioxide elimination, or both. Respiratory failure may occur because of impaired gas exchange, decreased ventilation, or both. Common manifestations include dyspnea, use of accessory muscles of respiration, tachypnea, tachycardia, diaphoresis, cyanosis, altered consciousness, and without treatment, eventually obtubation, respiratory arrest, and death. Diagnosis is clinical, supplemented by measurements of arterial blood gases, ABGs, and chest X-ray. Treatment is usually in an intensive care unit and involves correction of the underlying cause, supplemental oxygen and ventilatory assistance if needed. The respiratory system oxygenates and eliminates carbon dioxide from venous blood. Thus, a useful classification of respiratory failure is whether the principal abnormality is inadequate oxygenation, inadequate carbon dioxide elimination, which means inadequate ventilation. Many disorders affect both, although temporizing measures exist. Respiratory failure frequently necessitates invasive or non-invasive mechanical ventilation. Respiratory failure can be categorized mechanistically on the basis of pathophysiologic derangements in respiratory function. Type 1 of respiratory failure, acute hypoxemic respiratory failure. Type 2 is a consequence of alveolar hypoventilation by impaired central nervous system, drive to breathe, impaired strength with failure of neuromuscular function in the respiratory system and increased loads on the respiratory system. Type 3 results from lung atelectasis, and type 4 results from hypoperfusion of respiratory muscles in patients in shock. Now about type 1, acute hypoxemic respiratory failure, AHRF, IRDS. Acute hypoxemic respiratory failure is severe arterial hypoxemia that is refractory to supplemental oxygen. It's caused by intrapulmonary shunting of blood resulting from airspace filling or collapse. Findings include dyspnea and tachypnea. Diagnosis is by ABGs and chest X-ray. Treatment usually requires mechanical ventilation. This type of respiratory failure occurs with alveolar flooding and subsequent intrapulmonary shunt physiology. Alveolar flooding may be a consequence of pulmonary edema, lung injury, pneumonia, or alveolar hemorrhage. Pulmonary edema can be further categorized as occurring due to elevated pulmonary microvascular pressures, as seen in heart failure and intravascular volume overload or IRDS. Type 1 respiratory failure occurs in clinical settings such as sepsis, gastric aspiration, pneumonia, near drowning, multiple blood transfusions, and pancreatitis. Here you see pressure-volume relationship in the lungs of a patient with acute respiratory distress syndrome, IRDS. At the lower infection point, collapsed alveoli begin to open and lung compliance changes. At the upper deflection point, alveoli become over-distended. The shape and size of alveoli are illustrated at the top of the figure. Etiology. Airspace filling is acute hypoxemic respiratory failure. May result from elevated alveolar capillary hydrostatic pressure as occurs in left ventricular failure or hypervolemia. Increased alveolar capillary permeability as occurs in any of the conditions predisposing to acute respiratory distress syndrome, IRDS. Blood of inflammatory exudates in pneumonia or other inflammatory lungs conditions. And now pathophysiology. IRDS is divided into three categories of severity: mild, moderate, and severe, based on oxygenation defects and clinical criteria. The mild category corresponds to the previous category termed acute lung injury. The natural history of IRDS is marked by three phases: exudative, proliferative, and fibrotic, that each have characteristic clinical and pathologic features. You see here different IRDS categories. Mild level is 200 millimeter mercury, less partial pressure of oxygen is more than 200 millimeter mercuries, and less than 300 millimeter mercuries with PEEP or CPAP more than 5 centimeter H2O. In moderate category of RDS, we have PaO2 and FiO2 ratio more than 100 millimeter mercury and less than 200 millimeter mercury with PEEP more or equal 5 centimeter H2O. And severe category is when partial pressure of oxygen and FiO2 ratio is less than 100 millimeter mercury with PEEP more than 5 centimeter of H2O. Now clinical criteria: timing, imaging, and origin of edema. Timing when onset within 1 week of known insult or of new or worsening respiratory symptoms. Imaging: bilateral opacities not fully explained by effusions, lobar or lung collapse or nodules. The origin of edema: respiratory failure not fully explained by heart failure or fluid overload. As we told before, as we mentioned before, we have exudative, proliferative, and fibrotic phases. And here you see diagram illustrating the time course for the development and resolution of IRDS. The exudative phase is notably for early alveolar edema and neutrophil-rich leukocytic infiltration of the lungs, with subsequent formation of hyaline membranes from diffuse alveolar damage. Within 7 days, a proliferative phase ensues with prominent interstitial inflammation and early fibrotic changes. Approximately 3 weeks after the initial pulmonary injury, most patients recover. However, some patients enter the fibrotic phase with substantial fibrosis and bulla formation. In RDS, pulmonary or systemic inflammation leads to release of cytokines and other pro-inflammatory molecules. The cytokines activate alveolar macrophages and recruit neutrophils to the lungs, which in turn release leukotrienes, oxidants, platelet activating factors, and proteases. These substances damage capillary endothelium and alveolar epithelium, disrupting the barriers between capillaries and air spaces. Edema fluid, protein, and cellular debris flood the air spaces and interstitium, causing disruption of surfactant, air space collapse, ventilation perfusion mismatch, shunting, and pulmonary hypertension. The air space collapse more commonly occurs in dependent lung zones. Causes of RDS may involve direct lung injury, for example, pneumonia, acid aspiration, and indirect lung injury like sepsis, pancreatitis, massive blood transfusion, non-thoracic trauma. Sepsis and pneumonia account for about 60% of cases. Here we have causes of RDS. Common causes are acid aspiration, and it causes sepsis, pneumonia, trauma with prolonged hypovolemic shock. Less common causes, we have amniotic fluid embolism, diffuse alveolar hemorrhage, in case of bone marrow transplantation, fat embolism and burn traumatic situations, lung transplantation, which causes cardiopulmonary bypass, near drowning, like drug overdose, example aspirin, cocaine, opioids, phenothiazine, tricycline, pulmonary contusion with massive blood transfusion, more than 15 units, and last toxic gas inhalation, like neurogenic pulmonary edema due to stroke, seizure, head trauma, anoxia. Also, we have pancreatitis, preeclampsia, radiographic contrast, and septic abortion. Exudative phase of RDS. In this phase, alveolar capillary endothelial cell and type 1 pneumocytes, alveolar epithelial cells, are injured, with consequent loss of the normally tight alveolar barrier to fluid and macromolecules. Edema fluid that is rich in protein accumulates in the interstitial and alveolar spaces. Here you see a representative antero-posterior chest X-ray in the exudative phase of RDS, which shows bilateral opacities consistent with pulmonary edema that can be difficult to distinguish from left ventricular failure. In exudative phase, pro-inflammatory cytokines like interleukin-1, interleukin-8, and tumor necrosis factor, and lipid mediators, for example, LeuKO-3 and B, are increased in this acute phase, leading to the recruitment of leukocytes, especially neutrophils, into the pulmonary, interstitium, and alveoli. In addition, condensed plasma proteins aggregate in the air spaces with cellular debris and dysfunctional pulmonary surfactant to form hyaline membrane walls. Pulmonary vascular injury also occurs early in IRDS with vascular obliteration by microthrombi and fibrocellular proliferation. Here you see the normal alveolus and the injured alveolus in the acute phase of acute lung injury and the acute respiratory distress syndrome. In exudative phase of IRDS, alveolar edema predominantly involves dependent portions of the lung with diminished aeration. Collapse of large sections of dependent lung can contribute to decreased lung compliance. Consequently, intrapulmonary shunting and hypoxemia develop and the work of breathing increases, leading to dyspnea. The pathophysiologic alterations in alveolar spaces are exacerbated by microvascular occlusion that results in reductions in pulmonary arterial blood flow to ventilated portions of the lung and in pulmonary hypertension. Thus, in addition to severe hypoxemia, hypercapnia, secondary to an increase in pulmonary dead space can be prominent in early IRDS. The exudative phase encompasses the first 7 days of illness after an exposure to a precipitating IRDS risk factor, with the patient experiencing the onset of respiratory symptoms, although usually presenting within 12 to 36 hours after the initial insult. Symptoms can be delayed by 5 to 7 days. Dyspnea develops with a sensation of rapid, shallow breathing and inability to get enough air. Tachypnea and increased work of breathing result frequently in respiratory fatigue and ultimately in respiratory failure. Chest-computed tomography, CT, in IRDS also reveals the presence of bilateral pulmonary infiltrates and demonstrates extensive heterogeneity of lung involvement. Here we have a representative CT scan of the chest during the exudative phase of acute respiratory distress syndrome, in which dependent alveolar edema and atelectasis predominate. In proliferative phase, this phase usually lasts from day 7 to day 21. Most patients recover rapidly and are liberated from mechanical ventilation during this phase. Despite this improvement, many patients still experience dyspnea, tachypnea, and hypoxemia. Some patients develop progressive lung injury and early changes of pulmonary fibrosis during the proliferative phase. Histologically, the first signs of resolution are often evident in this phase, with the initiation of lung repair, the organization of alveolar exudates, and a shift from neutrophil to lymphocyte-predominant pulmonary infiltrates. As part of the reparative process, type 2 pneumocytes proliferate along alveolar basement membranes. These specialized epithelial cells synthesize new pulmonary surfactant and differentiate into type 1 pneumocytes. Fibrotic phase. While many patients with IRDS recover lung function 3-4 weeks after the initial pulmonary injury, some enter a fibrotic phase that may require long-term support on mechanical ventilators and/or supplemental oxygen. Histologically, the alveolar edema and inflammatory exudates of earlier phases convert to extensive alveolar duct and interstitial fibrosis. Marked disruption of acinar architecture leads to emphysema-like changes with large bulla. Intimal fibroproliferation in the pulmonary microcirculation causes progressive vascular occlusion and pulmonary hypertension. The physiologic consequences include an increased risk of pneumothorax, reductions in the lung compliance, and increased pulmonary dead space. Patients in this late phase experience a substantial burden of excess morbidity. Lung biopsy evidence for pulmonary fibrosis in any phase of RDS is associated with increased mortality risk. In both types of IHRF, flooded or collapsed spaces allow no inspired gas to enter, so the blood perfusing those alveoli remains at the mixed venous oxygen content no matter how high the fractional inspired O2, FiO2. This effect ensures constant admixture of deoxygenated blood into the pulmonary vein and hence arterial hypoxemia. In contrast, hypoxemia that results from ventilating alveoli that have less ventilation than perfusion. Low ventilation to perfusion ratios as occurs in asthma or COPD, and to some extent in IRDS, is readily corrected by supplemental oxygen. Symptoms and signs. Acute hypoxemia may cause dyspnea, restlessness, and anxiety. Signs include confusion or alteration of consciousness, cyanosis, tachypnea, tachycardia, and diaphoresis. Cardiac arrhythmia and coma can result. Respiratory opening of closed airways causes crackles detected during chest auscultation. The crackles are typically diffuse, but sometimes worse at the lung bases, particularly in the left lower lobe. Jugular venous distension occurs with high levels of positive and expiratory pressure, PEEP, or right ventricular failure. Now about diagnosis. We should diagnostic criteria for RDS. You see here mild, acute. Now we have mild, moderate, and severe. Mild, as we mentioned before, partial pressure of oxygen and IO2 ratio is more than 200 millimeters mercury and less than 300 millimeter mercury. Moderate between 100 and 200 millimeters mercury, and severe less than 100 millimeter mercury. Acute onset in acute phase, we have within 1 week of a clinical insult or new or worsening respiratory symptoms. Chest radiograph shows bilateral opacities consistent with pulmonary edema not fully explained by effusions, lobar lung collapse, or nodules. In supplemental oxygen does not improve the oxygen saturation to more than 90%. Right to left shunting of blood should be suspected. An obvious alveolar infiltrate on chest X-ray implicates alveolar flooding as the cause, rather than an intracardiac shunt. However, at the onset of illness, hypoxemia can occur before changes are seen on X-ray. Once IHRF is diagnosed, the cause must be determined, considering both pulmonary and extrapulmonary causes. Sometimes a non-ongoing disorder, for example, acute myocardial infarction, pancreatitis, sepsis, is an obvious cause. In other cases, history of suggestive pneumonia should be suspected in an immunocompromised patient, and alveolar hemorrhage is suspected after bone marrow transplantation or in a patient with a connective tissue disease. Frequently, however, critically ill patients have received a large volume of intravenous fluid for resuscitation, and high-pressure IHRF resulting from treatment must be distinguished from an underlying low-pressure AHRF, for example, caused by sepsis or pneumonia. High-pressure pulmonary edema is suggested by a third heart sound, jugular venous distension, and peripheral edema on examination, and by the presence of diffuse central infiltrates, cardiomegaly, and an abnormally wide vascular pedicle on chest X-ray. The diffuse bilateral infiltrates of IRDS are generally more peripheral. Focal infiltrates are typically caused by lobar pneumonia, atelectasis, or lung contusion, although echocardiography may show left ventricular dysfunction, implying a cardiac origin. These findings is not specific because sepsis can also reduce myocardial contractility. You see X-rays, which shows opacities, bilateral multiply opacities. You see normal, and in case of abnormal phase of RDS, the CT scan of RDS. When RDS is diagnosed but the cause is not obvious, a review of drugs and recent diagnostic test procedures and treatments may suggest an unrecognized cause, such as use of radiographic contrast agent, embolism, or transfusion. When no predisposing cause can be uncovered, some experts recommend doing bronchoscopy with bronchoalveolar lavage to exclude alveolar hemorrhage and eosinophilic pneumonia, and if this procedure is not revealing, a lung biopsy to exclude other disorders like extrinsic allergic alveolitis, acute interstitial pneumonitis. Because the early features of RDS are not specific, alternative diagnosis must be considered. And a differential diagnosis of RDS, the most common disorders are cardiogenic pulmonary edema, bilateral pneumonia, and alveolar hemorrhage. Less common diagnoses to consider include acute interstitial lung diseases like acute interstitial pneumonitis, acute immunologic injury, toxin injury, and neurogenic pulmonary edema. How can we treat? First of all, mechanical ventilation if saturation is less than 90% on high flow oxygen. Underlying conditions must be addressed as discussed elsewhere on this slide. AHRV is initially treated with high flows of 70 to 100% oxygen by a non-rebirth face mask. If oxygen saturation is more than 90% is not obtained, mechanical ventilation probably should be instituted. Specific management varies by condition. Nearly all patients require mechanical ventilation, which in addition to improving oxygenation, reduces oxygen demands by resting respiratory muscles. Targets include plateau alveolar pressures less than 30 centimeters, H2O, factors that potentially decrease chest wall and abdominal compliance considered. Tidal volume, 6 milliliter per kilogram predicted body weight to minimize further lung injury. FiO2 as low as is allowed to maintain adequate saturation of O2 to minimize possible oxygen toxicity. PEEP should be high enough to maintain open alveoli and minimize FiO2 until a plateau pressure of 28 to 30 centimeters of H2O is reached. Patients with moderate to severe IRDS are the most likely to have mortality reduced by use of higher PEEP. NIPPV is occasionally useful with IRDS. However, compared with treatment of cardiogenic pulmonary edema, higher levels of support for a longer duration are often required, and EPAP of 8 to 20 centimeters is often necessary to maintain adequate oxygenation. Achieving this expiratory pressure requires inspiratory pressures more than 18 to 20 centimeters, which are poorly tolerated. Maintaining an adequate seal becomes difficult, the mask becomes more uncomfortable, and skin necrosis and gastric insufflation may occur. Also, NIPPV-treated patients who subsequently need intubation have generally progressed to more advanced conditions than if they had been intubated earlier. Thus, critical desaturation is possible at the time of intubation. Intensive monitoring and careful selection of patients for NIPPV are required. Conventional mechanical ventilation in IRDS previously focused on normalizing ABG values. It's now clear that ventilating with lower tidal volumes reduces mortality. Accordingly, in most patients, tidal volume should be set at 6 milliliter on kilogram, ideal body weight. This setting necessitates an increase in respiratory rate, even up to 35 minutes, to produce sufficient alveolar ventilation to allow for adequate carbon dioxide removal. On occasion, however, respiratory acidosis develops, some degree of which is accepted for the greater good of limiting ventilator-associated lung injury and is generally well tolerated, particularly when pH is more than 7 and 15. If pH drops below 7.15, bicarbonate infusion or tromethamine may be helpful. Because hypercapnia may cause dyspnea and cause the patient to breathe in a fashion that is not coordinated with the ventilator, analgesics, fentanyl or morphine, and sedatives may be needed. Sedation is preferred to neuromuscular blockade because blockade still requires sedation and may cause residual weakness. PEEP improves oxygenation in IRDS by increasing the volume of aerated lung through alveolar recruitment, permitting the use of a lower FiO2. The optimal level of PEEP and the way to identify it have been debated. Recently, routine use of recruitment maneuvers followed by decremental PEEP titration was found to be associated with an increased 28-day mortality. Therefore, many clinicians simply use the least amount of PEEP that results in an adequate arterial oxygen saturation on a non-toxic FiO2. In most patients, this level is a PEEP of 8 to 15 centimeters, although occasionally patients with severe IRDS require levels more than 20 centimeters. In these cases, close attention must be paid to other means of optimizing oxygen delivery and minimizing oxygen consumption. The best indicator of alveolar overdistension is measurement of a plateau pressure through an end inspiratory hold maneuver. It should be checked every 4 hours and after each change in PEEP or tidal volume. The target plateau pressure is less than 30 centimeters of H2O. If the plateau pressure exceeds this value and there is no problem with the chest wall that could be contributing, the physician should reduce the tidal volume in 0.5 to 1 milliliter kilogram increments as tolerated to a minimum of 4 milliliter kilogram, raising the respiratory rate to compensate for the reduction in minute ventilation and inspecting the ventilator waveform display to ensure that full exhalation occurs. The respiratory rate may often be raised as high as 35 minutes before overt gas trapping due to incomplete exhalation results. If plateau pressure is less than 25 centimeters and tidal volume is less than 6 milliliter kilogram, tidal volume may be increased to 6 milliliter kilogram or until plateau pressure is more than 25 centimeters. Some investigators believe pressure control ventilation protects the lungs better, but supportive data are lacking, and it's the peak pressure rather than the plateau pressure that is being controlled. With pressure control ventilation, because the tidal volume will vary as the patient's lung compliance evolves, it's necessary to continually monitor the tidal volume and Adjust the inspiratory pressure to ensure that the patient is not receiving too high or too low a tidal volume. Prone positioning improves oxygenation in some patients by allowing recruitment of non-ventilating lung regions. A recent study suggests this position may improve survival. Optimal fluid management of patients with IRDS balance the requirement for an adequate circulating volume to preserve and organ perfusion with the goal of lowering preload and thereby limiting transudation of fluid in the lungs. A large multicenter trial has shown that a conservative approach to fluid management in which less fluid is given shortens the duration of mechanical ventilation and ICU length of stay when compared with a more liberal strategy. However, there was no difference in survival between the two approaches, and use of a pulmonary artery catheter also did not improve outcome. Patients not in shock and candidates for such an approach but should be monitored closely for evidence in decreased and organ perfusion, such as hypotension, oliguria, thready pulses, or cool extremities. A definitive pharmacologic treatment for IRDS that reduces morbidity and mortality remains elusive. Inhaled nitric oxide, surfactant replacement, activated protein C, and many other agents directed at modulating the inflammatory response have been studied and found not to reduce morbidity or mortality. Some small studies suggest that systemic corticosteroids may be beneficial in late-stage IRDS, but a larger prospective randomized trial found no reduction in mortality. Corticosteroids may be deleterious when given early in the course of the condition. The type 2 respiratory failure. This type of respiratory failure is a consequence of alveolar hypoventilation and results from the inability to eliminate carbon dioxide effectively. Mechanisms are categorized by impaired central nervous system, drive to breathe, impaired strength with failure of neuromuscular function in the respiratory system, and increased load on the respiratory system. Reasons for diminished CNS drive to breathe include drug overdose, brainstem injury, sleep disordered breathing, and severe hypothyroidism. Reduced strength can be due to impaired neuromuscular transmission, for example, myasthenia gravis, Guillain-Barré syndrome, amyotrophic lateral sclerosis, or respiratory muscles weakness, myopathy, electrolyte derangements, fatigue. Type 3 respiratory failure results from lung atelectasis. Because atelectasis occurs so commonly in the perioperative period, this form is also called perioperative respiratory failure. After general anesthesia, decreases in functional residual capacity lead to collapse of dependent lung units. Such atelectasis can be treated by frequent changes in position, chest physiotherapy, upright positioning, and control of incisional and abdominal pain. Non-invasive positive pressure ventilation may also be used to reverse regional atelectasis. Type 4 respiratory failure results from hypoperfusion of respiratory muscles in patients in shock. Normally, respiratory muscles consume less than 5% of total cardiac output and oxygen delivery. Patients in shock often experience respiratory distress due to pulmonary edema in cardiogenic shock, for example, lactate acidosis, and anemia. In this setting, up to 40% of cardiac output may be distributed to the respiratory muscles. Intubation and mechanical ventilation can allow redistribution of the cardiac output away from the respiratory muscles and back to vital organs while the shock is treated. Hypoperfusion, regardless of cause, may result in respiratory failure through inadequate delivery of oxygen to respiratory muscles coupled with excess respiratory muscles load and acidosis sepsis. Mechanical ventilation is useful for diverting blood flow from overworked respiratory muscles to critical organs such as the brain, kidney, and gut. Now, about disorders of ventilation. Ventilation is the process whereby the lungs replenish the gas in the alveoli. Measurements of ventilatory function in common diagnostic use consist of quantification of the gas volume contained in the lungs under certain circumstances and the rate at which gas can be expelled from the lungs. You see here the balance between load and neuromuscular competence determines the ability to sustain alveolar ventilation. On left side we have load, on right side strength. Resistive loads, lung elastic loads, chest wall elastic loads, and minute ventilation loads. On the right side, we have depressed drive, like drug overdose, brainstem, lesion, sleep disorder, breathing, hypothyroidism. Impaired neuromuscular transmission includes phrenic nerve injury, cord lesion, neuromuscular blockers, aminoglycosis, Guillain-Barré syndrome, myasthenia gravis, amyotrophic lateral sclerosis, and botulism. And muscle weakness include fatigue, electrolyte derangements, malnutrition, hypoperfusion states, hypoxemia, myopathy. PaCO2 levels are inversely related to VA. Increased minute volume, decreased partial CO2. Decreased minute volume, increased partial CO2. Minute volume is tidal volume minus dead space volume, respiratory rate. And we can control alveolar minute ventilation by changing respiratory rate, changing tidal volume. Alveolar hypoventilation exists when arterial PCO2 increases above the normal range of 37 to 43 millimeter mercury. Hypoventilation disorders can be acute or chronic. Chronic hypoventilation can result from numerous disease entities. You see here chronic hypoventilation syndromes. Impaired respiratory drive site of defect is peripheral and central chemoreceptors, and disorder caused by this syndrome, carotid body dysfunction, trauma, prolonged hypoxemia, metabolic alkalosis. And then you see also in impaired respiratory drive mechanism, we have brainstem respiratory neurons. Another mechanism are defective respiratory neuromuscular system and impaired ventilatory apparatus, which include chest wall and airways and lungs. In chest wall, you see hyposcoliosis, fibrothorax, thoracoplasty, so on and so on, and airways and lungs, laryngeal and tracheal stenosis, and also COPD, cystic fibrosis. Here we have psychological and clinical features of alveolar hypoventilation. And primary physiologic events, secondary physiologic events, and clinical features we have here on this diagram. Investigation of a patient with chronic hypoventilation involves several laboratory tests that will usually localize the disorder to the metabolic respiratory control system, the neuromuscular system, or the ventilatory apparatus. In contrast to patients with disorders of the respiratory control or neuromuscular systems, patients with disorders of the chest wall, lungs, and airways typically demonstrate abnormalities of respiratory system resistance and compliance and have a widened PO2. Because of the impaired mechanics of breathing, routine spirometric tests are abnormal, as is the ventilatory response to chemical stimuli. Here you see pattern of laboratory test results in alveolar hypoventilation syndromes based on the site of defect. AA gradient or alveolar arterial gradient is the difference in partial pressure PO2 between the alveolar PO2 and arterial PO2. Normally there is a mismatch between ventilation and perfusion in the lungs. PaO2 and arterial PaO2 are not the same. Calculation of AA gradient is useful in differentiating causes of hypoxemia. Decreased PaO2 referred to Hypoxemia due to a pulmonary cause, for example, acute respiratory distress syndrome, increases the alveolar arterial gradient. Hypoxemia due to an extrapulmonary cause, for example, paralysis of the diaphragm, does not increase the AA gradient. PaO2 equals 0.02, 70-13 arterial PCO2 0.8 ratio. Percent of O2 is the percentage of O2 the patient is breathing. 713 is the atmospheric pressure. 760 minus the water power pressure, 47 millimeter mercury, and 0.8 is the respiratory quotient. Example of an AA calculation using normal values. Normal PaO2 equals 0.21 minus 40.08 ratio equals 100 millimeter hydrargyrum. Normal patch AO2 equals 95 millimeter hydrargyrum. Normal AA gradient is 100 millimeters mercury minus 95 milligram mercury equals 5 millimeter mercury. Medically significant AA gradient is more than 30 millimeter mercury. Normally, this gradient decreases with age. More than 30 millimeter mercury is set for the highest specificity. A normal value for AA gradient varies with age and can be approximated with the following formula. AA equals age and 4 ratio plus 4. Hypoxemia with an increased AA gradient is a ventilation defect. Alveoli are perfused, however, there is impaired O2 delivery to alveoli. Example, airway collapse, atelectasis due to the respiratory distress syndrome. Perfusion defect can cause these changes in gradient. Alveoli are ventilated, but there is no perfusion of the alveoli. Pulmonary embolus, for example, and diffusion defect. O2 cannot diffuse through the alveolar capillary interface because of interstitial fibrosis, pulmonary edema, right to a left cardia shunt, for example, tetralogy of Fallot. Depression of the respiratory center in the medulla. Example is barbiturate overdose, brain injury. Upper airway obstruction example include epiglottitis due to Haemophilus influenza and group due to parainfluenza virus, mucosal edema narrows the trachea. Chest billows, muscles of respiration, dysfunction. Examples include paralyzed diaphragm, amyotrophic lateral sclerosis with degeneration of anterior bone cells. The management of chronic hypoventilation must be individualized to the patient's particular disorder, circumstances, and needs, and should include measures directed toward the underlying disease. Administration of supplemental oxygen is effective in attenuating hypoxemia, polycythemia, and pulmonary hypertension, but can aggregate CO, carbon monoxide retention, and the associated neurologic symptoms. Most patients with chronic hypoventilation related to impairment of respiratory drive or neuromuscular disease eventually require mechanical ventilatory assistance for effective management. For patients who require ventilatory assistance only during sleep, positive pressure ventilation through a nose mask is the preferred method because it obviates a tracheostomy and avoids the problem of upper airway occlusion that can arise in a negative pressure ventilator. Hypoventilation syndromes are primary alveolar hypoventilation, PAH, respiratory neuromuscular disorders, obesity, hypoventilation syndrome. Primary alveolar hypoventilation is a disorder of unknown cause characterized by chronic hypercapnia and hypoxemia in the absence of identifiable neuromuscular disease or mechanical ventilatory impairment. PAH is usually progressive over a period of months to year and is ultimately fatal. The key diagnostic finding in PAH is a respiratory acidosis in the absence of respiratory weakness or impaired ventilatory mechanics. Respiratory neuromuscular disorders, several primary disorders of the spinal cord, peripheral respiratory nerves, and respiratory muscles produce a chronic hypoventilation syndrome. Generally, respiratory neuromuscular disorders do not result in chronic hypoventilation unless the patient has significant weakness of the diaphragm. The management of patients with chronic alveolar hypoventilation caused by respiratory neuromuscular disease involves treatment of the underlying disorders when feasible and mechanical ventilatory assistance as described for the PAH syndrome. Massive obesity represents a mechanical load to the respiratory system because the added weight on the rib cage and abdomen serves to reduce the compliance of the chest wall. As a result, the functional residual capacity is reduced, particularly in the recumbent posture. In many patients, obstructive sleep apnea is a prominent feature. Alveolar hyperventilation exists when partial pressure of CO2 decreases below the normal range of 37 to 43 mm mercury. Hyperventilation is not synonymous with hyperpnea, which refers to an increased minute volume of ventilation without reference to a PI CO2, partial pressure of CO2. Although hyperventilation is frequently associated with dyspnea, patients who are hyperventilating do not necessarily complain of shortness of breath, and conversely, patients with dyspnea need not be hyperventilating. You see hyperventilation syndromes like hypoxemia, pulmonary disorders, cardiovascular disorders. Hypoxemia includes high altitude pulmonary disease, cardiac shunts. Pulmonary disorders are pneumonia, interstitial pneumonitis, fibrosis, edema, pulmonary emboli, vascular disease, bronchial asthma, pneumothorax, chest wall disorders. Cardiovascular disorders are congestive heart failure, hypertension. Metabolic disorders are acidosis, diabetics, also renal and lactic, hepatic failure. Neurologic and psychogenic disorders include psychogenic or anxiety, hyperventilation, central nervous system infection, tumors. Drug-induced situations are salicylates, methylxanthines, derivatives, beta-adrenergic agonists, progesterone, and miscellaneous like fever, sepsis, pain, pregnancy. Here you have schematic diagram of the mechanisms involved in alveolar hyperventilation. In most patients with a hyperventilation syndrome, the cause is readily apparent on the basis of history, physical examination, and knowledge of coexisting medical disorders. Investigation begins with arterial blood gas analysis, which establish the presence of alveolar hyperventilation and its severity. Equally important is the arterial pH, which generally allows the disorder to be classified as either a primary respiratory alkalosis, elevated pH, or a primary metabolic acidosis, decreased pH. Also of importance is the partial pressure of O2 and calculation of the IA gradient, PO2. The disorders that most frequently give rise to unexplained hyperventilation and pulmonary vascular disease, and psychogenic or anxiety hyperventilation. Hyperventilation caused by pulmonary vascular disease is associated with exertional dyspnea, a widened AA gradient, PO2, and maintenance of hyperventilation during exercise. In contrast, patients with psychogenic hyperventilation typically complain of dyspnea at rest, but not during mild exercise, and of the need of sight frequently. Mild alveolar hyperventilation is usually of relatively minor clinical consequence and therefore is generally managed by appropriate treatment of the underlying cause. For patients with disabling psychogenic hyperventilation, careful explanation of the basis of their symptoms can be reassuring and is often sufficient. Others have benefited from beta-adrenergic antagonists or an exercise program. Specific treatment for anxiety may also be indicated. Ventilation perfusion. Hyperventilation and excessive increase in pulmonary ventilation that exceeds the metabolic demands of the body, and it can change the blood chemistry, lead to respiratory alkalosis. Hyperpnea, an increase in the depth in the respiration rate during exercise or painful stimuli, but it doesn't change the blood chemistry. And tachypnea, accelerated respiration. In health, the arterial level of carbon dioxide is maintained between 37 and 43 millimeter mercury at sea level. All disorders of ventilation result in abnormal measurements of partial pressure of CO2. The continuous production of CO2 by cellular metabolism necessitates its efficient elimination by the respiratory system. The relationship between CO2 production and partial pressure of CO2 is described by the equation. Partial CO2 equals K VCO2 VA ratio, where VCO2 represents the carbon dioxide production. K is a constant and VA is fresh gas alveolar ventilation. VA can be calculated as minute ventilation, where the dead space fraction VT ratio represents the portion of a tidal breath that remains within the conducting airways at the conclusion of inspiration and so does not contribute to alveolar ventilation. As such, all disturbances of partial pressure of CO2 must reflect altered CO2 production, minute ventilation, or dead space fraction. Minute alveolar ventilation refers to the volume of gas inhaled during 1 minute period. Minute ventilation VE, tidal volume, respiratory rate, normal minute ventilation 5 to 10 liters per minute. Diseases that alter VCO2 are often acute, sepsis, burns, or hyperexia, for example. Chronic ventilator disorders typically involve inappropriate levels of minute ventilation or increased dead space fraction. The spontaneous cycle of inspiration and expiration is automatically generated in the brainstem. Two groups of neurons located within the medulla are particularly important: the dorsal respiratory group and the ventral respiratory column. They initiate activity in the phrenic nerve, project to the upper airway muscle groups and spinal respiratory neurons, and innervate the intercostal and abdominal muscles that participate in normal respiration. The DRG acts as the initial integration site for many of the afferent nerves, relaying information about PaO2, PaCO2, pH, and blood pressure from the carotid and aortic chemoreceptors and baroreceptors to the central nervous system. In addition, the vagus nerve relays information from stretch receptors and juxtapulmonary capillary receptors in the lung parenchyma and chest wall to the DRG. The respiratory rhythm is generated with the VRS as well as the more rostrally located parafacial respiratory group, which is particularly important for the generation of active expiration. One particularly important area within the VRS is the so-called Prebotzinger complex. This area is responsible for the generation for various forms of respiratory activity. The neural output of this medullary respiratory networks can be voluntarily suppressed or augmented by input from higher brain centers and the autonomic nervous system. During normal sleep, there is an attenuated response to hypercapnia and hypoxemia, resulting in mild nocturnal hypoventilation that corrects upon awakening. Once neural input has been delivered to the respiratory pump muscles, normal gas exchange requires an adequate amount of respiratory muscle strength to overcome the elastic and resistive loads of the respiratory system. In health, the strength of the respiratory muscles readily accomplishes this, and normal respiration continues indefinitely. Reduction in respiratory drive or neuromuscular competence, or a substantial increase in respiratory load, can diminish minute ventilation, resulting in hypercapnia. Here you see excess respiratory muscle strength in health. Diseases that reduce minute ventilation or increase dead space fall into four major categories: parenchymal lung and chest wall disease, sleep-disordered breathing, neuromuscular disease, respiratory drive disorders. The clinical manifestations of hypoventilation syndromes are non-specific and vary depending on the severity of hypoventilation, the rate at which hypercapnia develops, the degree of compensation for respiratory acidosis, and the underlying disorder. Here we have diagram signs and symptoms of hypoventilation. Dyspnea during activities of daily living. Orthopnea and diseases affecting diaphragm function. Poor quality sleep, daytime hypersomnolence, early morning headaches, anxiety, impaired cough in neuromuscular disease. Patients with parenchymal lung or chest wall disease typically present with shortness of breath and diminished exercise tolerance. Episodes of increased dyspnea and sputum production are hallmarks of obstructive lung diseases such as COPD, whereas progressive dyspnea and cough are common in interstitial lung diseases. Excessive daytime somnolence, poor quality sleep, and snoring are common among patients with sleep-disordered breathing. New-onset orthopnea is frequently a sign of reduced respiratory muscle force generation. The clinical course of patients with chronic hypoventilation from neuromuscular or chest wall disease follows a characteristic sequence. An asymptomatic stage where daytime PaO2 and PaCO2 are normal, followed by nocturnal hypoventilation, initially during rapid eye movement, sleep, and later in non-REM sleep. Finally, if vital capacity drops further, daytime hypercapnia develops. Symptoms can develop at any point along this time course and often depend on the pace of respiratory muscle functional decline. Regardless of cause, the hallmark of the alveolar hypoventilation syndromes is an increase in alveolar PCO2 and therefore in PaCO2. The resulting respiratory acidosis eventually leads to a compensatory increase in plasma bicarbonate concentration. The increase in partial pressure of CO2 results in an obligatory decrease in PaO2, often resulting in hypoxemia. If severe, the hypoxemia manifests clinically as cyanosis and can stimulate erythropoiesis and so induce secondary erythrocytosis. The combination of chronic hypoxemia and hypercapnia may also induce pulmonary vasoconstriction, leading eventually to pulmonary hypertension, right ventricular hypertrophy, and right heart failure. Elevated plasma bicarbonate in the absence of volume depletion is suggestive of hypoventilation, and arterial blood gas demonstrating elevated partial pressure of CO2 with a normal pH confirms chronic alveolar hypoventilation. The subsequent evaluation to identify an etiology should initially focus on whether the patient has lung disease or chest wall abnormalities. Physical examination, imaging studies, and pulmonary function tests are sufficient to identify most lung chest wall disorders leading to hypercapnia. If these evaluations are unrevealing, then the clinician should screen for obesity, hypoventilation syndrome, the most frequent sleep disorder leading to chronic hypoventilation, which is typically accompanied by obstructive sleep apnea. If the ventilatory apparatus is not responsible for chronic hypercapnia, then the focus should shift to respiratory drive and neuromuscular disorders. There is an attenuated increase in minute ventilation in response to elevated CO2 and or low O2 in respiratory drive disorders. These diseases are difficult to diagnose and should be suspected when patients with hypercapnia are found to have normal respiratory muscle strength, normal pulmonary function, and normal alveolar arterial PO2 difference. Brain imaging, CT scan or MRI, can sometimes identify structural abnormalities in the pons or medulla that results in hypoventilation. Chronic narcotic use of significant hypothyroidism can depress the central respiratory drive and lead to chronic hypercapnia as well. Measurement of maximum inspiratory and expiratory pressures or forced vital capacity can be used to monitor for respiratory muscle involvements in diseases with progressive muscle weakness. These patients also have increased risk for sleep disorder, breathing, including hypopneas, central and obstructive apneas, and hypoxemia. Nocturnal non-invasive positive pressure ventilation, NIPPV, has been used successfully in the treatment of hypoventilation and apneas, both central and obstructive, in patients with neuromuscular and chest wall disorders. Nocturnal non-invasive positive pressure ventilation has been shown to improve daytime hypercapnia, prolong survival, and improve health-related quality of life when daytime hypercapnia is documented. ALS guidelines recommend considerations of nocturnal ventilation if symptoms of hypoventilation exist and one of the following criteria is present: PaCO2 more than 45 mg mercury, nocturnal oximetry demonstrates oxygen saturation less than 88% for 5 consecutive minutes, maximal inspiratory pressure less than 60 centimeter of H2O, and FBC less than 50% predicted. Sniff nasal pressure less than 40 centimeter HO2. At some point, the institution of full-time ventilator support with either pressure or volume pressed bottles is required in progressive neuromuscular disorders. Treatment of chronic hypoventilation from lung or neuromuscular diseases should be directed at the underlying disorder. Pharmacologic agents that stimulate respiration, such as medroxyprogesterone and acetazolamide, have been poorly studied in chronic hyperventilation and should not replace treatment of the underlying disease process. Regardless of the cause, excessive metabolic alkalosis should be corrected, as plasma bicarbonate levels elevated out of proportion for the degree of chronic respiratory acidosis can result in additional hypoventilation. When indicated, administration of supplemental oxygen is effective in attenuating hypoxemia, polycythemia, and pulmonary hypertension. However, in some patients, supplemental oxygen can worsen hypercapnia. Phrenic nerve or diaphragm pacing is a potential therapy for patients with hypoventilation from high cervical spinal cord lesions or respiratory drive disorders. Prior to surgical implantation, patients should have nerve conduction studies to ensure normal bilateral phrenic nerve function. Diagnosis of obesity hypoventilation syndrome requires BMI more than 30 kg and chronic daytime alveolar hypoventilation, defined as partial CO2 more than 45 mm mercury at sea level in the absence of other known causes of hypercapnia. In almost 90% of cases, the sleep disorder breathing is in the form of OSA. The treatment of obesity hypoventilation syndrome is similar to that for OSA. Weight reduction and nocturnal non-invasive positive pressure ventilation. Continuous positive airway pressure CPAP improves daytime hypercapnia and hypoxemia in more than half of patients with OHC and concomitant OSA. This syndrome, the syndrome of central hypoventilation syndrome, can present later in life or in the neonatal period, where it's often called underlying scars or congenital central hypoventilation syndrome. Abnormalities in the gene encoding PHOX2B, a transcription factor with a role in neuronal development, have been implicated in the pathogenesis of CCHS. Regardless of the age of onset, these patients have absent respiratory response to hypoxia or hypercapnia, mildly elevated PaCO2 while awake, and markedly elevated PaCO2 during non-REM sleep. These patients typically require nocturnal ventilation or mechanical ventilation as therapy and should be considered for phrenic nerve or diaphragmatic pacing. Hyperventilation is defined as ventilation in excess of metabolic requirements, CO2 production, leading to a reduction in PaCO2. The physiology of patients with chronic hyperventilation is poorly understood and there is no typical clinical presentation. Symptoms can include dyspnea, paresthesia, tetany, headache, dizziness, visual disturbances, and atypical chest pain. Patients with chronic hyperventilation present to a variety of healthcare providers, including internists, neurologists, physiologists, psychiatrists, and pulmonologists. Then, ensuing onset of chest pain, breathlessness, paresthesia, or altered consciousness can be alarming. An unrevealing evaluation of causes of their symptoms often results in patients being anxious and fearful of additional attacks. It's important to know that anxiety disorders and panic attacks are not synonymous with hyperventilation. Anxiety disorders can be both an initiating and sustaining factor in the pathogenesis of chronic hyperventilation, but these are not necessary for the development of chronic hypocapnia. Respiratory symptoms associated with acute hyperventilation can be the initial manifestation of systemic illness such as diabetic ketoacidosis. Causes of acute hyperventilation need to be excluded before a diagnosis of chronic hyperventilation is considered. Arterial blood gas sampling that demonstrates a compensated respiratory alkalosis with a near normal pH, low partial CO2, and low calculated bicarbonate are necessary to confirm chronic hyperventilation. Other causes of respiratory alkalosis, such as mild asthma, need to be diagnosed and treated before chronic hyperventilation can be considered. A high index of suspicion is required as increased minute ventilation can be difficult to detect on physical examination. Once chronic hyperventilation is established, a sustained 10% increase in alveolar ventilation is enough to perpetuate hypocapnia. This increase can be accomplished with subtle changes in the respiratory pattern, such as occasional sigh breaths or yawing 2-3 times per minute. There are few well-controlled treatment studies of chronic hyperventilation owing to its diverse features and the lack of universally accepted diagnostic processes. In some patients, reassurance and frank discussion about hyperventilation can be liberating. Identifying and eliminating habits that perpetuate hypocapnia, such as frequent yawing or side breathing, can be helpful. Some evidence suggests that breathing exercises and diaphragmatic retraining may be beneficial for some patients. The evidence for using medications to treat hyperventilation is scant. Beta blockers may be helpful in patients with sympathetically mediated symptoms such as palpitations and tremors. And this was last slide. Thank you for your attention.